morning. Good morning, everyone, and thank you so much for that kind introduction. My name is Dr. Jamie Terry, and as Peggy so eloquently stated, my passion is to combine my sociology experience with my years of practice. Today, I'm honored to talk about something that's near and dear to all of us that very much want to make healthcare and the interaction between patients and the healthcare system better. And that starts with the patient-practitioner relationship. Communication barriers are well known. So let's talk about how to talk to your doctor about your fears. Forbes and the Forbes Council have done a beautiful job of outlining just some basic essential communication practices of effective leaders. Physicians should be leaders of the healthcare system. And I would like to think that physicians are also advocates. These 5 canons really have to do with authenticity and trust. If we start with the first one, it says, mind the say-do gap. It is key that leaders and individuals who are communicating mean what they say and they can deliver what they say they will. As a communicator and as a physician, it's going to be important that I communicate the limitations of my abilities to not only solve healthcare problems, but to meet the expectation and needs of my patients. And then I must be able to deliver that in not only the care I provide, but in the experience that my patients have, in the office. Second, my job is to make what can be very complex simple. This does not mean dumbing down the process. This does not mean talking down to patients. And this does not mean insulting anyone's intelligence. But healthcare has become increasingly complex. Avenues for treatment as well as options are vast. So a good leader, a good communicator can make what is a very overwhelming and complex topic simple in the context of what is most cogent or important to the patient and their family. Thirdly, each individual in the communication spectrum needs to find their own voice. What that means is my job is not merely to look smart in front of my patients, nor is it the job of any doctor to just simply recapitulate or sound like a textbook. In order to find your own voice, the physician has to spend time in training, communicating, and knowing where they have bias, both conscious and unconscious, and how that bias can be relayed in an honest and transparent way so that patients feel comfortable that their best interest is at heart, but that the physician is human. Fourth, all effective leaders, communicators, and advocates are visible. Another term is present. It's easy for physicians to become distracted. It's easy for them to appear disengaged and distracted by circumstances and surroundings. There are a lot of things pulling on physicians, a lot of demands, but being visible, making eye contact in the room, and reading the room and the expressions and the body language of their patients, not only with their ears through listening, but with their eyes, is really very important. And then last but not least, it really is very important for all this to come together, as I mentioned previously, and is to listen, is to listening. Listening is just a key component of what needs to be done to be an effective communicator. And listening with your eyes as well as your ears, which means making eye contact, letting people in the room know that you see them, is critical. I'd like to talk a little bit about perspective, understanding that, of course, the patient and the practitioner are coming from a different perspective. These perspectives are outlined by the AMA. In 1999, they began to shift their focus from teaching communication skills on rounds with young doctors merely in the form of being able to repeat medical terms and terminology with proficiency and efficiency, to being able to communicate that to the patients. So I apologize, there'll be a credit at the end, but this is really from the AMA. Patient concerns / fears can be wide-ranging. When there's a life-threatening condition, such as in my practice, where I deal mostly with cancer of the breast in particular, fear of death and fear of realizing one's own mortality can be at the forefront. Additionally, as a surgeon, I have to be cognizant and aware, as well as intimately sensitive to mutilation. Surgery can cause deformity, issues with body image, and strains on an interpersonal relationship because of issues with mutilation, deformity that surgery can produce. Disability, in interfering with autonomy and independence, fear of pain and suffering, and a topic that I'd be very interested in engaging the participants in, which is distrust of the medical profession. Science and the medical profession over the last several years have really been under assault. There is history to support this concern and hesitancy. The history is not only ethnic in origin, but it is cultural and religious in origin, and it should be acknowledged as well as discussed with the patient and the practitioner if it is of concern to the situation being addressed. Loss of independence and denial are not joined, but many people value their independence and their ability to be autonomous. And surgery, as well as a healthcare challenge, really calls that into a very fragile state. Denial is something that's just a natural response, a human behavioral response to something that is distasteful and scary and life-threatening. Grief is something that's expressed in different ways by different people, and it's something that the practitioner needs to be receptive to, as well as attuned to. And fear of being displaced from their homes, especially in the elderly, the idea of a disability, a health challenge, putting them in a nursing home or causing them not to be able to live in their home is a large fear that needs to be addressed. Let's talk about the practitioner. The 5 A's that the American Medical Association says are key to practitioner communication effectively is the ability to assess, advise, agree, assist, and arrange. I'd like to deconstruct each one of those a little bit. Assess has everything to do with what I've bolded here, which is listening. Listening is a skill that not all of us possess well. And more importantly, it's something that with training, time, and interest, it can be improved and cultivated upon. When you listen, you're also then better able to assess what's wrong with the patient, how they feel about the condition. What is their knowledge base? How much do they understand before they come to you? How much of what they understand do you need to dispel because perhaps it's not based in what you understand to be the facts? So assessment is not merely a physical examination by the practitioner. It's an assessment of the knowledge and understanding of the patient, as well as their perspective on the illness or the concern that they're coming to the doctor for. Advise. We no longer practice paternalistic medicine, which means it is no longer the function of the physician to give orders, to give direction without listening to the patient and providing them with advisement that they take under consideration. And then there's a shared decision-making. Lastly, agreement. And I expand upon this in one of my last slides. Patients don't have to have agreement with their physician about their plan of care. They can agree that the patient is informed and refuses the treatment, or they may agree that the patient understands their options and they give consent. So there's informed consent and there's informed refusal. It is the job of the practitioner to provide all aspects of this, and then for the patient and the practitioner to come together in agreement about how to move forward. They don't have to necessarily agree about the medical approach. Assist. The healthcare system is complex, it's challenging, it's overwhelming. It's important when a doctor outlines a treatment plan, when the doctor and the patient have a shared decision on how to move forward. The doctor must assist the patient in understanding exactly what can or cannot be done to assist them with achieving the outcome that they desire. Because the doctor is not in full control. The patient may think so, the doctor may wish that they were, but there are resource allocations, there are healthcare, unfortunately, economic and insurance constraints that the physician must assist the patient in understanding could limit what both of them agree to as a desired plan. So the doctor needs to assist the patient with understanding the healthcare system. Last but not least, it's arrangement. This is the extension from the physician to their office, to social work, to the team, be it palliative care or another subspecialty. It's to arrange and assist with referrals, as well as arrange and assist with the patient getting where they need to go, who the point person in the office is, so that calling, getting a voicemail, seeing something in the physician or in the patient portal that's scary or confusing, this technology, this openness of the medical record, it can also accentuate fears, and there should be an arrangement as to how these questions are going to be handled by the physician in their office. Let's talk a little bit about fear. Effective communication is as much about authenticity as it is words, because fear is not rational, it's visceral, it's a response to a circumstance and a situation. Transparency, honesty, provides a framework for the patient and the practitioner to do those 5 things that are critical to effective communication, starting with agreeing upon the goals of care. Specifically, in my circumstance, you have breast cancer. What are your goals? I want to be cured, Dr. Terry, says the patient. We share the same goal. So we start there. We share the same goal. We come to agreement that I hear you and you hear me. Let's build upon that. Agreement requires that both parties be heard. An alternate response would be, Dr. Terry, I just don't want to be cut on. I saw that you were a surgeon. I didn't know that's where I was coming. I didn't know that's who you were. So I'm hearing the patient. I'm a surgeon, but I'm a doctor first. So because I'm a surgeon, that's my specialty, but that's not what I do. What I do is care for patients. Tell me about your fears surrounding surgery. What do you understand about your illness that makes you think that surgery is the only option? Opening up the conversation, dispelling the fear that you come into a surgeon's office and immediately the conversation is only focused around cutting or surgery. Through active listening, both the patient and the practitioner are armed with information to assist in achieving goals through either informed consent. Well, now that I've heard that the surgery is not as scary as I thought, or now that I've heard that the surgery may unfortunately require more deforming than I had hoped for, I didn't know I could be cured. I didn't know there was a 98% chance cure with surgery. So I'm listening. I consent to surgery. Let's talk about details. Dr. Terry, I understand. Whatever you say to me, I will not have surgery. Okay, that's an informed refusal. Okay, since we can't go what I believe is the most efficient route for cure, let's talk about other options that would participate in cure. Let me refer you to other doctors that could perhaps provide you with other options medically to treat your problem. And that is a transparency, a willingness to listen, and a receptiveness by the practitioner to accept informed refusal. This is my last slide. I hope I haven't taken up too much time. I've been very careful with watching my time. The web of belief is a concept that was advanced by a philosopher by the name of Quinine and Ullin in 1978. They were philosophers at Harvard University. And the web of belief is a concept where everyone understands that each person in a conversation, no matter how serious or seemingly mundane, brings a web of belief to the conversation that, whether consciously or unconsciously, frames how they perceive the world and their perspective on a situation. So within the patient-practitioner relationship, within the concept of overcoming fears and barriers to communication, I invite all of you participants to share with me and for me to share with you how we can bring web of belief into the consciousness of the patient-practitioner communication. Because pretending that it's not there serves no one. Acknowledging the web of belief where there's bias on the part of the physician or the healthcare provider, or biased or beliefs on the care of the patient, only informs and makes the relationship richer and more efficient. Thank you so much for your time. Ms. Peggy?
Who would like to ask the first question? If you want to be shy, I'll ask the first question, but I want to make this y'all's meeting and not my meeting.
Please. I can hear you, Peggy, but I can't hear anyone else. So
well, they haven't unmuted themselves. Cody, do you have to unmute everybody or can they unmute themselves?
Here, let me, did I do something wrong here? Let me see.
No, you did nothing wrong.
Okay.
They can unmute themselves. I'm unmuted.
Okay.
But I don't have any questions. You're remarkable. I loved hearing from you.
Thank you, Ms. Alexander.
So I was sharing this story with Cody before we came live, and I first met Dr. Terry many years ago, probably more years ago than either one of us want to admit, when I was helping to facilitate a breast cancer support group at Memorial Hermann Memorial City. And she did a wonderful presentation. And at the end of the presentation, folks were asking questions, which we hope you'll do. And somebody asked her an unanswerable question, but I love Dr. Terry's response because she looked at them with all earnestness and said, my title is doctor, not GOD. And that's the first time I've ever heard a doctor admit they weren't God. And so
you don't have a crystal ball. She doesn't have a crystal ball.
Well, I think analogy is powerful. And while I have a lot of credentials and initials behind my name, MD is not GOD, right? They're different. And so I think if patients understand, my quest is to help and inform, but I do not for one moment pretend to have all the answers or be right. Patty, you said you had a question? I'd like to hear from my participants.
I said I don't. I said it was just good to hear from you.
Thank you so much.
So I'll start with a question. You bring up such an important question about listening. And as some of you may know, one of my jobs in the past has included teaching medical students at UTMB and some other places as well. But I've had students and doctors at CME presentations say to me, oh, we don't have the time. And the research shows that many doctors, and certainly Dr. Terry is not one of them, but many doctors have been shown to interrupt the patients after 15 seconds. And yet when they timed how long the doctor needed to listen, it was 90 seconds. And so I would invite you to comment on how we as patients force the doctors to listen, because when you talk about that fear response, lots of things are coming from fear. So how do we ask those questions, and how do we make sure that we're heard?
First of all, in the spirit of true transparency, Peggy will also tell you that I'm constantly late, which means I'm very blessed to have patients that will endure, and I admit it, endure the wait times in my office. But I also believe that part of the reason that they endure the wait times is because they say to themselves, I know how long Dr. Terry's been in the room here with me.
Mhm.
So if she was rushing out of the room with me, I know because I was in the waiting room that there's 8 other people. So how I should wait because she isn't rushing me. So since she's not rushing me, I shouldn't be ugly to her and her staff because I've had to wait for her. But I'm just being honest. And I think, and Peggy can attest to this, I'm not making excuses for the wait times in my office. I think with patients that I have another topic I want to talk about with, my established patients that I have a rapport with, it doesn't take as long physically for us to connect and them feel that connection with me, them feel attended to, because they already know me and they know that I've paid attention. When I walk in the room, I ask them questions from a visit 4 months ago. So they know that I remember them. I see them. Patients want to be seen. How's your mother? She's not here with you today. Where's that handsome son that came with you last time? I know your husband must trust me because this is the first time he's ever come to one of your visits. They appreciate that. Let's give some functional tools. Everyone, and it's common knowledge that patients should make a list. They should make a list of questions that they have that include, this is something extra, that include exactly what they know and what they don't know. The biggest challenge that I think I have with patients is they will come with a list, but they come with a list of answers or impressions. They don't, and they come with a list of questions and they already have Googled, talked to a friend. So they end up not doing the reverse. They end up not doing active listening because with the question comes a preconceived answer or response. And not that it's incorrect, but then they're interrupting, right? The very things that they don't want the doctor to do, they do. And that makes the visit take much longer. The job of an effective communicator is to be patient in the assessment and listening process. But then again, that takes us back to the economics of healthcare. There is time. Let's do something. Let's mention something else because I anticipated this question, Peggy. Let's also talk about scheduling of the appointment. If you know you are an information seeker, if you know you have a list of more than 5 questions, you should say, I have a lot of questions. May I email them to you or the doctor in advance? Okay. Is there going to be an opportunity for me to give you the questions so the doctor may be prepared? I am willing to come more than once because is my appointment a 30-minute appointment because I'm a new patient? If you're an established patient, is it 15? Patients are consumers, but just like you don't buy every pair of shoes, you try them on first. You should be knowledgeable about your appointment, but you should understand and assume the doctor wants to do their best and give them that tool, okay? Last but not least, let's also be very clear about the need to do research. Every opinion of the doctor on the internet is probably only about 30% true. Because when patients are super happy, they're not running home and getting on their computer and typing a long page about how much time the doctor spent with them and how wonderful they are, because they're able to leave the doctor's office and move on with their life. And that's what they're supposed to do. But if they're disgruntled, they were late, but then they wanted to let their husband in, then they were mad because the COVID wouldn't let their husband in, then it's a problem. So those are just a couple of things that I would suggest. I don't want to dominate. Let's get some more questions. Did you have another question, Miss Peggy? Or Nicole?
Somebody
Welcome.
just came on.
Yes, hello. I did have a question actually. So I'm a mental health provider, and a number of my clients are seeing surgeons, seeing psychiatrists, seeing PCPs. I wanted to kind of hear some suggestions as to how I can best be part of the treatment team and facilitate communication between the parties.
Good question.
I'm sorry, your role is what again? I'm sorry. I
She's
missed
a
the-
mental health provider.
So you're a what is your exact title? I'm sorry.
It's okay. I'm a mental health counselor. So I provide psychotherapy.
Okay. So in my practice, and this is a very challenging topic, only because most patients actually, and please call me Jamie, Dr. Terry, I want this to be interactive. And I can only see Nicole, so I apologize that I don't know your last name. Nicole, most patients are not forthcoming with their mental health conditions. So the challenge as the physician is that active listening, that assessment with your eyes as well as your ears. Is there a small tremor? Is there fidgeting? There's anxiety. Is there measured, pressured speech? Right? This requires that the doctor put on that hat as well and try to ferret out that mental health information in a non-biased, non-judgmental, non-confrontational way. So from my standpoint, this all starts for our interaction, you and me, with you getting informed consent from the patient to be able to have their healthcare information shared with you. Because I can tell you, I can count on one hand the number of patients that have been forthcoming about bipolar disorder that is stabilized on medication, anxiety that is stable or unstable on medication, things like Tourette's, which aren't really, it's not necessarily, it has a diagnosis in that spectrum, autism spectrum disorder, gender confusion, or gender dysphoria, I should say. I apologize for that. Gender dysphoria. Many patients are not forthcoming. They are very fearful of being judged, of being treated differently, being treated like they are inferior, receiving less than quality care. So from my standpoint, us partnering with you, helping patients understand that if they go to a doctor's office and they're forthcoming with their mental health challenge and they get anything other than a vibe or a sense or a rapport of not necessarily empathy, because that can make patients very angry too, but of a what? Openness. It's a transparency. Well, I see. I understand. Thank you for sharing with me that you're counselors, Nicole. Do I have your permission to share your information, or could we discuss, could I call her and discuss what we've talked about today that you're fearful of as it relates to your surgery, so we can both support you? But see, if I don't have that information, if you don't empower the patient and the family to trust the healthcare provider with being open and honest, it's not till I go to the medication list. And I'm a surgeon. So frequently I have to try to ferret out these medications that someone that's very buttoned up and packaged. Do I know that I need to explore this? So that's really a barrier for me.
Definitely. Thank you for sharing that.
No, but it's critical because I had a sister that suffered with mental illness. So I'm very sensitive to this. I see a lot of patients with mental illness. It's amazing how your reputation, around the city, a lot of patients with autism spectrum disorder, because that nonverbal sense that I'm here to help you, that I try to communicate. I don't know sign language. Please don't misunderstand me. But when I know a patient's nonverbal, someone with dementia or someone on the spectrum that's nonverbal, I have 2 or 3 patients actually that their oncologist called me. No one will do surgery on them. I can't do whatever. I say, well, I need to see them. I need to walk in the room and I need to see how they respond to me. And frequently, if I can break down that barrier non-verbally, I frequently, Peggy will tell you, I don't wear a white coat all the time in my office, because some patients, that's the first way for them to they zone out. It's a visceral response. They're so nervous with that white coat and all my badges and all my initials that it's just game over. So those are some of the tools that I used to teach. I don't teach residents anymore. I'd like to start again from a different perspective, not just the doctor, but more from the ethical communication perspective. Sometimes that white coat does not serve you well. Taking off the white coat disarms you, not in your ability to communicate, but it disarms you from the bias, right? From the preconceived notion that here comes someone with a paternalistic attitude that's going to sweep in here and take over. But the cancer's already taken over. I don't want to feel more victimized. I want to be empowered. So I have no problem disarming that and not wearing the white coat.
I'd like to follow up on something you said about patients who have dementia or other things going on. I always encourage people, and then I know in the time of COVID it's been challenging, but to bring someone else to critical appointments so that they're two sets of ears listening to what's going on. How important is that?
It's a double-edged sword. If I'm going to be perfectly honest, it's a double-edged sword. It's okay if you're bringing someone who comes to the visit as ears and advocate. But unfortunately, we know that everyone brings their web of belief and experiences to all interactions. So frequently, it's important that the two people are actually as close as they say they are. That's another thing. Illness can bring people together out of concern that haven't otherwise spoken to each other or had a meaningful conversation in a while, right? So then when you bring that into the doctor's office, the doctor's trying to navigate what is not only somewhat of a strained relationship between the two. I feel guilty. I should have been in touch with her. Now I'm here. She has cancer. So it's almost a little bit too much. They'll take over the conversation and not allow me to develop that rapport and not allow the patient to be heard. I need to take the time to empower the patient to find their voice. Each one of those things that I said make for an effective communicator and an advocate. Each one of those things have a duality. Both the patient and the practitioner need to do that. I need to empower my patient to have and find their own voice. I cannot let cancer rob them of that. You are not a mute. You are overwhelmed. You are afraid, but you have your voice. We are going to get through this together. Talk to me. Let me meet you where you are and bring you where you want to go. Each one of those things, self-advocacy. Okay, Dr. Terry, I hear you, but how am I going to do that? You're a cutting doctor, don't you, you know what I'm saying? Right, but so now, even if it's off topic, it's not about their case. Now you're talking, right? You're crying. I just can't believe this happened to me. How did God let this happen to me? I don't believe this is true, right? So at least then I have a glimpse into their web of belief. I understand what is behind their denial. It's fear, but it's religion. It's religion being used as a shield. It's a shield to protect them from what they feel is an assault, right? Right. So, I mean, I could go on about tools. It's another conversation. Overcoming barriers is one thing. Finding the tools to deconstruct and disarm those barriers and fears is probably another conversation. But that's my thought. Bonnie, do you have any thoughts? I see you're on the screen, but you're muted.
I'm not very good at unmuting myself. I'm an independent patient advocate. So before the pandemic, I went with a lot of the clients to doctor's visits. And I found that a lot of my clients would, they'd be like a deer in the headlights when they got into the doctor's office. Like this one client, older client, was getting ready to move to another city to be closer to their adult children. And the radiation oncologist was like, okay, well, we're going to do 6 weeks of, radiation, blah, 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 blah. And I thought, wait a minute, they've got to pack and they've got to move. And this person just in there going, okay. I'm going, excuse me. Could I just say something here where, this needs to be maybe, doctor, we need to talk about maybe doing the treatment in the new city or bridging the treatment options, or, so I find a lot that my clients won't say what they tell me is most important to them in the doctor's office. So the dynamic is I'm kind of wondering about that dynamic, because I feel like I'm the one bringing it up, like what's most important to them.
Well, that communication barrier has more to do, in my opinion, with the patient feeling paralyzed by their circumstances. Not that I'm not all for patient advocates, and God bless you for what you do. And, maybe one day we will get to a place in healthcare where advocates are compensated, because there's advocacy like you're doing, and there's advocacy that requires a lot more work because the patient just doesn't have the health literacy, right? They don't have the literacy to be able to understand and remember that radiation is every day, Monday through Friday. They have to plan for issues with transportation, tolls, what time of day, right? So even if they are in the same city, they have to rely upon the physician can perceive the patient as non-compliant, when that's not really the case. They're non-compliant because they don't have capacity to remember and understand the complexity of the recommended and agreed upon, right? The agreed upon regimen. So in that circumstance, I would like to think that physicians, when recommending a treatment, can deconstruct exactly what it means functionally. What do I mean by that? You're going to have breast conserving surgery, by example. And the standard of care for breast conserving surgery in your circumstance, I'm going to just say, use Bonnie arbitrarily, is that this would be followed by, 4 to 6 weeks of radiation therapy. The exact amount, time frame, and those complications will be outlined by the radiation doctor. But before we do that, I want you to understand what this means functionally. I'd like to pick a facility that is not only either close to your home or work, but that you know that you can get there every day, Monday through Friday, at that same time of day. You may be able to arrange with your employer, Dr. Terry, I've got to work. They're not going to let me off work. How? I can't pay for my insurance. I can't pay the copay for radiation if I don't work. I hear you, Bonnie. So maybe you can arrange with your employer to use your lunch hour to do that. Come in 30 minutes early, use your lunch hour, because there's a radiation facility that's one stop from your job. Oh, okay. Let me call there. Are they in the network? Let me find out if they're in your network. Oh, they're not in my network, Dr. Terry. What am I going to do? Where do you live? I live off of Highway 6 in Sugar Land. There are 2 freestanding facilities. One, you don't have to pay to park. So I'd like to decrease the financial toxicity of your care by suggesting you go there so you don't always have to pay for the gas back and forth, and you pay to park. See, and if you can go there, since it's close to your house, they have 7:30, 8 o'clock slots. So maybe you can go to work at 9, work through your lunch hour, or stay till 5:30, work this out with your employer. I would like to think that as a consumer, you are given all the information to receive the product that you come to the doctor for. And that is not just an answer. You need earrings to go with that outfit, right? You're right. I mean, I'm trying to make it simple, but it's really not complicated. Oh no, you look fantastic. but you could use a little lipstick to go with that blush. You need the doctor to help you put all the components together to get the best outcome. And so that's what I try to do as I recommend a treatment for my patient. Now, it gets complicated, Bonnie. I don't like that doctor. They were rude. They don't spend time with me like you do, Dr. Terry. Then that last component that I talked about in the slide, which was arranging and assisting, then comes the reality talk. While I wish everyone could have a close relationship with you, this relationship with the radiation experience is a month. So if you're getting quality care, I will try to speak to the nurse, the technician, the physician, but it's more important that you get there every day. It's close to your job, close to your work. It's not financially toxic so that you're not in hardship. Then it is that every time they go in, they remember your vacation schedule or your birthday, like my office might. It's setting realistic expectations too, right? So it's complex, and the healthcare system and the economics of the healthcare system are not kind to either the consumer or the worker bee. Patients, advocates, y'all have got to understand, not all doctors are not always the enemy. It is hard to do and give as much as needs to be given to provide good care in a global psychosocial sense. It is not easy. It is the exception and not the rule. What else?
Other questions? So I'd like to follow up on that. And so, Dr. Terry, with all due respect, I know what kind of a doctor that you are, and that you would lie down on I-10 if it would make your patients better and help them. But not everybody is like you. So my question is, how do we as healthcare users figure that out and advocate for ourselves to say to the doc, this is what I need from you?
I think outlining, and actually, like I said, I apologize. I will actually, with your help, Peggy, provide, because I didn't make a slide with the references for where I got some of those information. And I just gave kind of an overview credit, and I don't want to do that. I will provide a reference slide for some of these tools, but that the slide where I specifically talked about the 5 A's that are equally applicable to the patient and the doctor. Doctor, I want to do and adhere to the plan that we agreed upon. But I have to be honest with you about my bias. I wanted a female doctor, and there's only a male doctor in my plan. I need you to hear me, right? Right. It's feeling comfortable in your own skin in a circumstance when you feel very vulnerable. So communication is a two-way street. I see your office is packed, Dr. X. And I appreciate that I got squeezed in, right? It's for 1 minute being outside of yourself. The more a doctor perceives that the patient understands and gives them the benefit of the doubt, the better way to start off. If the doctor whizzes in and seems very busy and, goes right in with the physical exam or whatever, there's nothing wrong with saying, I can see you're very busy and I have some questions. Are we going to have time today to go over the questions? Or I made a copy for you. Can you look at them? Because you may be able to answer them very quickly, but I need to be able to take notes. So if I made a copy for you, it sounds almost reconciliatory, and I apologize if that's how it sounds. But the easiest way to disarm someone, and now I'm being devil's advocate, and all because I'm a doctor doesn't mean I'm not a patient. I've had to go to see specialists. The easiest way to disarm someone that is abrupt or someone that is terse, curt, is to be extremely polite and respectful. That is the quickest way to disarm that. And then if you just keep getting this barrage of, well, actually, no, we don't have that time to make that, to go over those questions today, then there's nothing wrong with saying, I understand that you have to examine me, but if there was no time for us to discuss and come to decisions together, then I'm not sure that you're the doctor for me. Straight up, right? Well, we can make time. We can make time to talk. I just don't have forever. Do you have a minute to sit down? I mean, do you have a moment to sit down? Right? Well, I had more questions, but here are the ones that are most important, right? You know what I'm saying? It's finding your voice in a circumstance. Again, it's almost as if you were talking to what? If you were talking to a special needs child that you knew meant no harm, but also did not have the tools to communicate with you the way that you wanted, you would try to disarm them and bring them into a circumstance where you two could communicate. Alternately, if this was your mother, your brother, your sister, and they had a competence issue, were on the spectrum, were older and demented, you would no more disrespect your mother and tell her she was rude and interrupting the doctor than the man in the moon. You would put your hand on her, lap, or you would say, I need for you just to give the doctor a minute to talk so that then we can discuss this later. Same thing with the physician. You know, I understand that you're busy and this is very easy for you, but it's hard for me. So if we can't answer all of my questions now, can we answer the two that I'm most fearful about? It's disarming the volatility and that distance with kindness and what? You being a good communicator. It works. I'm guilty. I have been exhausted. I've had to operate. I've had to do a case, and it turned out harder. I've had to add on a case because a patient's insurance is expiring the next day and they didn't know. So rather than have them be in tears, I've got to be 45 minutes late to the office. And then I've got to listen to patients complain about being 45 minutes late to the office, and they have breast pain, right?
Yeah.
And then they wonder why I'm tired and I don't have an hour to spend with them to tell them that their breast pain is not pathological. Doctors are human. We are human. Just like you don't know, I don't know what's happened in your life that day. I don't know what informs your web of belief. Right. You don't know what the doctor's been through that day. We got to work together.
We have time for one more question. No more questions?
I minimize the participants. Who else has a question? Peggy, did you have another question? Like maybe a set question?
I would like, let's close with this one.
Okay.
Talk a little bit about personalized medicine, the move towards that, and what that means for us. And I know you could probably spend a whole nother hour talking about that, but I think that's a terminology that we need to get familiar with, because I even see it in the newspaper.
Can you give a little bit from the consumer standpoint of the background of what you understand it to be?
Part of it is technology, and part of it is, and particularly, I think it's happening in cancer treatments, because we found, researchers have found that a cancer cell is not a cancer cell, that there are a gazillion different kinds of cancer cells. So one of the things that we're moving towards is evaluating the cancer cells to see what they are and how they respond to different treatments. And so that when you see on TV, for example, MD advertising about personalized medicine and that they will do a treatment plan just for you, that's what they're talking about.
Okay, I want to be mindful of the time. You're right. And we have about two or 3 minutes.
Right.
Peggy's going to shoot me, but I'm going to be No, I'm going to be 100% transparent here.
Okay,
Some of this is marketing.
yeah, okay,
Personalized medicine is it's the bar. I don't want my treatment plan as a African American female of midlife to be the same as a premenopausal Anishinaabe Zoo, a Jewish woman with a BRCA1 mutation that
mhm,
hasn't even had children yet, but wants to be a mother. So some of this is marketing.
okay.
Let's be perfectly clear.
Mhm,
Let's deconstruct that a little bit. With the advent of precision medicine
mhm,
and evidence-based medicine, the buzzwords that are much more scientific and medical, we are trying to take how cancer manifests in individuals,
mhm,
combine it with what we know about that patient population demographic and their underlying predispositions metabolically, as well as historically. Hypertension in African American men, diabetes in South Asian populations, Himalaya, right? And try to see how that could inform altering treatment plan, altering dosages, customizing the treatment plan so that metabolically the patients suffer fewer side effects from medications
mhm.
and more targeted therapy, which is what we call evidence-based and
Right.
personalized.
Okay, thank you. Somebody wrote in the chat, I would like to thank you so much for all this, even though we're talking about the field of medicine. I think it applies to day-to-day life communications too, in the workplace, etc. Thank you so, so much. I think that kind of summarizes it. And I thank you very much, Dr. Terry, for your time today
Thank
and
you.
for your life's work, because I know it makes a huge difference for a lot of people.